Thank you, Thomas, for talking about controlling for confounding. You may note that we didn't talk about controlling for bias, and that's because you largely, depending on the bias, can't. But that's an aside. Now we're going to talk about measures of association, and knowing measures of association is really important, not just for knowing how to interpret the results of your study, but also knowing how to read literature and interpret the results of other studies. And so measures of association are, of course, mostly concerned in our analysis of our data, but then the conclusions that we have, what we write and publish, and then generate new ideas from, all still center around these measures of association. So then what is a measure of association? And it's going to be just a value that enumerates or quantifies the relationship between your predictor and outcome. So once we've sampled from our target population, we have our study population, and we're analyzing our data, ultimately, instead of a p-value, what we really want to be looking at would be the measure of association for our data. So you can think of the 2x2 table that we've brought up several times today, and many of these measures of association are commonly found in epidemiology, but they're very common in clinical research as well. And so today we're going to go over relative risk, odds ratios, hazard ratios, the absolute risk difference, the number needed to treat, and the number needed to harm. Now, I broke the rules, and I know Dr. Mira said no equations, but I've provided them to you, not mostly for your own amelioration, to better understand what these concepts mean. So the relative risk, which may also be called a risk ratio, you can think of that as the incidence in the exposed divided by the incidence in the unexposed. So if you look at the equation there, the quantity A divided by A plus B is just going to be the proportion of people who experience the outcome who are in your predictor group. And then C divided by C plus D, that's going to be the proportion of people who experience the outcome in your comparison group. And so the relative risk is used most commonly in prospective studies because you're going to identify a group of patients, then ascertain either the predictor or exposure variable, and then you're going to follow them to look for outcomes. And it's most commonly used in randomized clinical trials because in these, you've already accounted for your confounding and bias. So the relative risk is a very strong measure of association then to look at who experienced an outcome and how to quantify that. So let's have an example. Let's say that we have 25 people in our predictor group who experienced the outcome and 5 people who did not. So what that would equate to is a relative risk of 5, meaning that people in the predictor group, so let's say we're looking at smoking and lung cancer, right? If the predictor is smoking and the outcome is lung cancer, in this example, they would be 5 times the risk of developing lung cancer for smoking. Now, this is a pretty extreme example. In most clinical studies, we don't see relative risks this high anymore. A lot of times, it's much smaller magnitudes of effect. But there's a purpose for why we chose such an extreme measure of effect. So then the next one we're going to talk about is the odds ratio. And so the odds ratio is, instead of looking at the predictor first and calculating it, we're looking at the outcome first and predicting it. So it's going to be the odds that in the group that experienced the outcome that they had met the exposure divided by the odds of those who did not experience the outcome that they had met the exposure. So the quantity A divided by C would be the odds that the outcome group had experienced the exposure, and the quantity B divided by D would be the odds that those who didn't experience the outcome had experienced the exposure. So that simplifies down to just AD divided by BC. And so it's a very simple way to calculate from a 2x2 table. And odds ratios are usually used in case control studies and other retrospective studies Additionally, a logistic regression, if you have a dichotomous variable, will produce an odds ratio. So if you look at the odds ratio for, say, you have a multivariable logistic regression, those odds ratios that you find are going to describe the increase in odds or decrease in odds potentially of a risk factor on an outcome. And because it's a multiple logistic regression, those are independent predictors. So then it's accounting for everything else in there. So that is how we would adjust for confounding, as Thomas brought up earlier. And the odds ratios, if the incidence of your outcome is small, the odds ratios do a good job of approximating our relative risk. But when the incidence grows, then it becomes a little bit less proficient, because the odds ratios will always overestimate the magnitude of effect. And when I say overestimate, I mean, if we have the same exact 2x2 table, our odds ratio is 6.3. And if you remember, our relative risk was 5.0. Likewise, if your odds ratio is less than 0, it's always going to be closer to 0 than a relative risk will be for the same group. Hazard ratios are a little bit different in that you can think of a hazard ratio as analogous to a relative risk, but at any point in time. And so hazard ratios are the effect, measure of effects that's generated by Cox proportional hazard regression. And so what that's saying is that the assumptions of that test are that at any given point in time, the risk that exists will be relative to some baseline rate. And so if we have a predictor variable, then the relative risk there, or should I say the hazard ratio, would be at any point in time the increased risk of experiencing that event. So a lot of times we think of like time to death, time to mortality, and survival analysis. So if someone has a hazard ratio of 1.2, that would mean that they are 1.2 times more likely to die at any given point in time. So then when we're interpreting these ratios, we have to remember that they're all ratios. So we're comparing them always to the number 1. And that means because they're ratios, we always have a numerator and a denominator. So typically, when we construct a relative risk or an odds ratio, we're usually looking at, say, a treatment or over a control, or if we are looking at risk factors, say in an observational study, we might be looking at those who are at risk divided by those who aren't at risk. And so when the numerator and denominator are equal, meaning that there is no association because they're the same, the ratio is going to be equal to 1. So then, again, remembering that they're ratios, they can go from anywhere from 0 to infinity. So if your odds ratio or relative risk is less than 1, that means that your denominator is going to be larger and that it will be less likely or lower odds. If your odds ratio or relative risk is above 1, that means your numerator is larger, and then it will be more likely or increased odds. But remember that the key word in relative risk is relative. So the issue with relative risk, and issue is a strong word, but one thing to consider is the baseline rate. So a relative risk and odds ratio provide the relative effects, but what if we want to know a more concrete effect size? So that's when we would start looking at the absolute risk difference or the absolute risk reduction. So, and this is more based on the baseline rate of an outcome happening. So in this case, remember the relative risk, we were previously dividing these two quantities. Now we're subtracting them. And it's absolute risk difference, so we take the absolute value. And so let's consider a study of a therapy that shows a 50% relative reduction in mortality. So that seems pretty awesome if 50% less people are dying. Now, if the baseline mortality rate's 40%, our absolute risk difference would be 20%, because 50% of 40% is 20%. But if our baseline mortality was 1%, then the absolute risk difference would be 0.5%, meaning we, 0.5% of patients survived from this. So that may not be clinically important, or it might be. It depends on your context. So here we have a relative risk of 0.5, and based on the actual percentage of absolute reduction, you can see that we have a 20% reduction, or 0.2. However, if we were to look at the same relative risk, but we were to have it as a 1% absolute reduction, this may not be clinically significant. Now, the reason why I have roughly 2,000 people in the treatment and control groups is because this is a statistically significant number of people to detect this difference. So, just trying to bring home that statistical significance does not necessarily imply clinical significance. Another way you can look at the absolute risk difference is if you flip it on its head, you can get the number needed to treat. So the number needed to treat could be, it's essentially looking at how many patients you would need to treat to prevent one bad outcome. So in our example, we had a 20% reduction in absolute risk difference. In this case, the number needed to treat with this new treatment to prevent one excess death would be 5 people. However, in the other case where we had a 1% difference in our absolute risk difference, the number needed to treat would be 100 people. So if you put that into perspective, clinically speaking, if you had the choice to treat a patient or not, like let's say that this is a new investigative drug and it costs 20 times the amount of the standard of care, you know, that may be something to consider for your clinical judgment. The number needed to harm is the inverse. So if we look at adverse events for an investigational drug, then the number needed to harm would essentially be the number needed to treat, but for bad outcomes. So we would find maybe for every 20 patients that are involved in this study or treated with this drug, we would see one adverse event, one serious adverse event compared to the control. And so we can think of an example for this recently with the Janssen vaccine for COVID. So in May, the CDC released information looking at thrombosis with thrombocytopenia syndrome, or I'm just going to call it TTS to avoid saying that again. But they found approximately 3.2 cases per million doses administered and almost 0.5 deaths per million doses administered. So if we were to convert that to the number needed to harm, that would mean that we had one case of TTS for roughly every 300,000 doses administered, and roughly one death from TTS for every 2 million doses administered. And at the time, I think there were maybe 9 to 10 million doses administered. So you can think of that as there were roughly 5 excess deaths from this vaccine due to this. And so because of this, the CDC's guidelines have changed and Janssen's no longer one of the recommended vaccines for COVID-19. So that's a real world example about how you can use these numbers. And that concludes kind of our overview on measures of association.